What to call intellectual disability? There actually is a minority of people that don't think we should call it anything. They say that sure, there may be differences in intellectual functioning among the population, but what our world should do is accept and embrace differences. And if we set up a world where there was truly universal design, and where we set up schools where every child was looked like as an individual and the schools taught to that child's needs, you really wouldn't have to make a distinction between sort of them and us. Scott Danforth is a person who will write about this now and then. I just remembered his name and looked up one of his old articles, and he is sort of against naming it because, as best I understand, it's almost like a postmodernist thought. It's like if you don't name it, it won't exist. And naming it and identifying it, in his mind, does more harm than good, because it results in people having lower expectations for students being put into separate places. And so there's a case to be made against naming it. In terms of the case for naming it, is that people can communicate about something that's important to communicate about. So if indeed there are differences between people with and without intellectual disability, and people with intellectual disability need extra help and extra support, you have to identify the disability as something in order to have some sort of discourse or communication about what needs to be done. And so in our society, obviously the namers have won out or dominate against the non-namers, but that whole issue of what to call it with this disability has been difficult over the years. And the reason why I think it's difficult is when you talk about intellectual disability and the focus is on the construct of intelligence, intelligence is a valued attribute. We had a baby, people would say, oh, what a beautiful, smart baby, and that would be like a compliment. So intelligence is something that we value as a society, we value in other individuals, we value in ourselves. And so if you're saying that this disability is evidence of a lack of intelligence, the name becomes awkward. We haven't been able to separate the notion that the disability is a problem, it's a bad thing, but the people are good things. All right, so what has happened is we call the disability becomes a characteristic, a defining feature of the person, and it seems like an insult or a put down. It seems like a bad thing. Some archaic terms were idiocy, feeble-mindedness, mental deficiency, and mental retardation. These terms weren't necessarily pejorative terms to start out with. They were clinical terms. And over time, they became pejorative, and they acquired so much baggage that people said, oh, we really need to change the term, because now it's no longer denotes a clinical understanding, it's kind of an insult. So the first time some mean little kid jumped on the playground and called somebody retarded, that term, mental retardation, began to acquire some baggage, some negative connotations, and then it became an insult versus clinical diagnosis. The current term, which I guess is debatable, it depends how current you are, but is intellectual disability, and that one, at least nationally and internationally, has won out over the competitors. Now, I heard cognitive disability earlier, and in the schools that is used. There are some people who don't like that term because they say, how can one's cognition be? You know, it's not an issue of mental processes and cognition and thinking. It's a term that deals with intelligence. Intellectual disability, the American Association on Intellectual Disability did choose it as a term, and there was like a debate for the longest time in terms of what to go to. Nobody was happy with mental retardation, but what to change it to. They felt that having disability in there was helpful because when we talk about it in a second, the social ecological thinking, it does provide the notion of this person needs some supports that others in society don't need. So it's a logical basis for understanding supports, better aligned with professional practices, widespread international usage, and that one I think is a valid reason. The field is increasingly becoming global, and although it's not universal, in England and the UK they still talk about learning disability being intellectual disability, so there is definitely still across the world some inconsistency, but intellectual disability is used in more places than other terms are. The real reason why it has emerged is because it's less offensive than mental retardation. Most of you are probably familiar with the Spread the Word to End the Word campaign that was launched by the Kennedy family and Special Olympics, and has gotten a lot of goodwill, and basically AAIDD and other disability organizations at some point had to let go of mental retardation and did switch to intellectual disability. Again, cognitive disability is used, I know, in the schools. Another name that you hear occasionally is people talk about developmental disability. That's interesting that has creeped into sort of language as a diagnostic term, because it was never a diagnostic term. It was a term that was, born and emerged from the DD Act. And in the 1960s, there was a big emphasis, I guess as there still is today, of deinstitutionalization, moving people out of large state-operated institutions back to the community and preventing people from, entering institutions. And developmental disability was identified as a term to talk about that traditional institutional population. So it was really a term that meant this person is receiving services. So identifying someone as a service recipient. And it was never meant to be a clinical term where someone makes a diagnosis and you have a disability. It's a developmental disability. Developmental disability meant that you had been identified and were eligible under the rules. But occasionally people will also just kind of use them interchangeably. What I want to point out, through all this, is the name is just what you're calling it. Okay? I've heard people get into debates and discussions about, is it intellectual disability, is it mental retardation, is it developmental disability, and some people will slip into talking about parameters or characteristics or diagnostic criteria. And that's a different issue than what you're going to name it. All right? And so with Rose's Law, which was signed by President Obama, I think in 2009, intellectual disability, at least, is the term used now in our federal laws and federal regulations, and seems to be the one that has emerged as, what to call it. Now, when you introduce a new term, people get nervous because a new term may mean different definitional boundaries. And when you talk about defining, that means explaining what the term means and establishing parameters for who is included and who is not. With intellectual disability, there was some nervousness because not only in IDEA and special education law was mental retardation used, but supplemental security income, a lot of families and a lot of people who've been determined eligible for income assistance through the federal government are very nervous about what I was determined eligible as a person with mental retardation. If you're changed it to intellectual disability, am I going to have to be re-diagnosed? So there's a lot at stake in terms of changing a term if it changes the population parameters. And so efforts were made to make sure this wasn't going to be the case. With the newest definitional manual that came out, we kept the definition exactly the same and said, like several places, the same population that was covered under the old term is covered under the new term. Defining, explaining the meaning, and establishing parameters for who is included and who is not. Intellectual disability has been around for truly about 250 years, if you talk about a written history of it. Now, it's obviously been around since the dawn of time if you're talking about the disability itself. But people started writing about it in the mid-1700s. And there was a clear distinction made between mental illness and intellectual disability. The two were confused, and then people said, no, there are people who have a mental illness and mental health needs, and that's different than people who have intellectual disability. And so for the first 100 years, let's go from 1800 to 1900, clinical judgment by a physician was used to make a diagnosis. There was no specific manual. At certain times there were some guidelines that somebody published or somebody wrote up. But the focus was on achievement and development, not on trying to discover an underlying trait or trying to put estimate on someone's potential. Okay, so if I was a family member or somebody else and I was concerned about this person, then we'd go to a doctor, and it was almost like if you had a cold or something, what are your symptoms or what are you experiencing, and the doctor would listen, do an interview. Again, there were some guidelines. They weren't necessarily standardized from physician to physician. But the things that they looked at were learning, and not necessarily academic learning, because a lot of the population was illiterate, okay? But does the person have a hard time following directions or learning tasks that other people seem to pick up much quicker? Community adaptation. Is the person able to get to and from places without getting lost? Is the person able to hold a job? Is the person able to make contributions here and there? So are they participating in their community, or are they a person who doesn't seem to be capable of independent participation like others? And then there was a lot of focus on social participation, especially vulnerability. Is the person likely to be exploited? Are they more gullible than others? So it was done through a physician interview. It wasn't necessarily consistent from person to person. But up until 1900, you went to a doctor. You get a diagnosis. Then things changed, and there's our picture of Binet, Alfred Binet. He came up with a test, and Binet's first IQ test wasn't called an IQ test. It was a test to predict which children would be having problems in school down the road. So Binet came up with a series of tests, and before a child failed in school, his idea was, let's identify those who are at risk for failure, and then let's do, these interventions. So I sound like I'm talking about RTI for a second, don't I? But I mean, Binet was a pretty optimistic fellow from my readings and my understanding. I mean, he had a program of mental calisthenics. And so his idea was you identify the kids who are at risk, and just like calisthenics build up the physical body, these mental calisthenics would build up the power of the mind. So he saw all of these things as malleable, and off he came with his test, and it got translated. And eventually, people came up with mental age scores. This is what a child of certain age should be able to do on this test, And if I scored on this test, I had a mental age of a 5-year-old or a 6-year-old or 7 years old. Then they took chronological age and they made the IQ quotient. Mental age / over chronological age gave your intelligence quotient. And then eventually with the Wechsler test, they changed all that to a standard deviation score. And so my point in bringing up this history, which I know you're all school psychologists and you're all familiar with it, but I think it's good to remind ourselves that there wasn't an initial effort to go in and discover what someone's intelligence was, and what the quantity was. This kind of came through a series of iterations. And in 1910, a group was put together, and by my association, American Association, AAIDD, back then it just had a horrible name. It was like the Association of Superintendents of Asylums for the Feeble-Minded or something like that, But, the group had this IQ test, and they all of a sudden said, based on these mental age scores, here's some different classifications, and the terms were just horrible. They had moron, imbecile, and idiot, but again, those terms weren't necessarily meant to be offensive at the time. But that was an important shift, because in the 1900s, psychologists became the diagnosticians instead of the medical doctors. So psychologists became the people who gave the IQ test. The IQ score was seen to be as more objective than a physician interview and the conclusions that a physician would come up with. And it was seen as a quick and efficient way to get information. You bring somebody in, you do these puzzles, do these things, score the form, and voila, you got it. With the IQ test, though, there was a shift that people didn't quite pick up on. And instead of measuring achievement and performance, what the person does, there all of a sudden was now this idea that we're measuring a trait, a human characteristic, in terms of intelligence. It was not without its critics. Sometimes we think the criticism of IQ started like in the 60s or something, but even at the time, now this was a journalist. He wasn't even a psychologist, but Walter Lippmann was his name. He was famous in the 20s, and I just liked his quote because I thought, boy, he was this hard-hitting person who was very concerned. I can't imagine a more contemptible proceeding than to confront a child with a set of puzzles, and after an hour's monkeying with them, proclaim to the child or to his parents that here is a C- individual. It would not only be a contemptible thing to do, it would be a crazy thing to do, because there is nothing in these tests to warrant a judgment of this kind. And so there was some kickback, some reaction to this notion of using an IQ score to make a diagnosis. We talked about how mental age scores gave way to deviation scores. And you're all familiar with this. They did change. I mean, they went to these different things when they sort of settled on 70. But in 1959, 1961, the AAIDD published what was truly their first manual. I mean, they call it like their 6th edition because they called these earlier papers. But they moved it up to 85. And so theoretically, 2.14% of the population all of a sudden became 16% of the population. Okay? And they moved it up to 85 because they said, now we're going to start measuring adaptive behavior. Okay? And the notion was that adaptive behavior would be this counterbalance to IQ. So there'd be some people who had a higher IQ score, but they had, some significant deficits in adaptive behavior. And there'd be some people with a lower IQ score, but didn't have deficits in adaptive behavior. So they went for a while from really 59 to 73 with an IQ of 85. And so this was the traditional 2x2 table that a psychologist would sort of use to guide their thinking. Were there IQ deficits? So from 59 to 73, was it 85 or below? All right. During every other time, was it 70 or below? Were there concurrent adaptive behavior deficits? Okay. So just as significant. They were basically talking about 70 or below, 2 standard deviations or below the mean. And if there were both adaptive behavior and IQ deficits, you could make a diagnosis of intellectual disability. Adaptive behavior sort of returned us to pre-1900 in a way, because adaptive behavior was now measuring achievement. What does a person do? What does a person not do? There was not this suggestion that adaptive behavior is a human trait. It's what you can do. Can you cross the street alone? It's on all sorts of adaptive behavior items. And not just one time make it across. Can you do it? Typical functioning on a regular basis. So it's what you can do, but now there was a way to kind of measure it and go through a standard series of questions as opposed to a physician interview. Adaptive behavior also was a big part of deinstitutionalization because people saw it as far more functional. If I know what someone's adaptive behavior is, it gives me goals to work on when they come back to the community. And there was this dissatisfaction with the power of just one IQ score. And this has continued to today, but adaptive behavior was put in as a dual criteria. And one of the notions was it was going to stop the overrepresentation, the over-identification of kids from poor and minority backgrounds. There was a thought that IQ was really related to academic achievement, and you would have these street smart, street savvy kids, and if they had high adaptive behavior scores, they would not be identified as children with intellectual disability. They may have some educational needs, but this would solve the problem. Well, as someone told us, and I forgot which psychologist it was, but a lot of school districts are still struggling with overrepresentation and disproportionality. And so adaptive behavior really did not serve as an effective counterbalance. However, this has remained the way diagnosis is basically still done today. Give an IQ test, measure adaptive behavior, and if there's evidence from both those sources of information that somebody has significant deficits, then a diagnosis of intellectual disability is considered to be appropriate. Okay? So defining, setting the parameters. And then classifying is dividing into groups what has been included within the boundaries of a term that has been defined. So once you define it, you now move to it's a heterogeneous group, and how are we going to classify people within that group? Prior to the 1900s, before we had IQ scores, people did try to classify. Dr. Down of Down syndrome fame, he had a very unfortunate ethnic classification system during the mid-1800s. And so most of you know that Mongolism was the old term for Down syndrome. I always thought that he just, picked that one out of the blue, but actually he had every racial ethnic group he thought, had some sort of disability that was stuck deep in their genes. And so he did his best to identify, he had something for Aztecs, he had something for, well, it didn't work out, and he realized that, and he gave that up. It was an example of somebody trying to classify by cause, by biological cause. When people classify by biological cause, it's not usually very helpful to educators, to someone who's trying to teach or to school, because even today you may hear of some rare syndrome, but it kind of leaves you a little flat in terms of, oh, well, that's interesting, but what does that tell me to do in terms of a teacher? But in terms of medical professionals, that classification can be quite helpful. The classic examples are PKU, phenylketonuria. I realize I'm getting old when I say this, but with this group I don't feel so bad. But my students at the university, they like, oh, wow, that was like, I was out there working with Dr. Down or something. But when I started working at camps when I was in high school for kids with intellectual and related developmental disabilities, there were several children at the camp, and they had these similar characteristics, and somebody would say, oh, that's a PKU child. And so phenylketonuria, just to refresh your memory, it results from an inability to digest amino acids, and a baby is born, and eventually a toxic level builds up in their body and it attacks the brain and causes brain damage, and the damage is permanent. But they were clever enough to realize that you can identify babies at birth with PKU, and the intellectual disability can be completely prevented if you put a child on a special diet that doesn't involve digesting amino acids. And at first, they would smell diapers for a certain smell, and then they got to a blood test, and now in every developed country, it's mandatory. It's a simple blood test. And it's an example of classifying by etiology that has paid great dividends, because there are not a bunch of PKU children in summer camps now. It's very rare in the United States. Somebody either has refused the blood test or it's been botched or something like that. So it has its place. Obviously, fetal alcohol syndrome. Hard to believe that at one point, people thought drinking during pregnancy was an okay thing to do. But at one point they said, oh, the placenta just, blocks that out. Well, now we know it doesn't. And so, it has its value for medical researchers, but for educational researchers, it hasn't had much usefulness. So how to classify if you're not going to classify by etiology? Of course, so many cases are unknown. The cause is unknown. That's a big problem with etiology. Well, they've classified by IQ score. Has been the traditional way. Borderline, moron, imbecile, and idiot were the first categories. Educationally, we had just as bad as ones, quite frankly. My teaching certificate, did they have that in Indiana? They had trainable? Up until the 2000s, Illinois, it's finally, they gave us a new one, but When you think about it, educable, trainable, custodial weren't really any better, especially trainable. That sounds, very insulting to me. Today, they just, it's level of deficits: mild, moderate, severe, and profound. These terms maybe not as offensive, but mild to me has always been troubling, because individuals who get that classification is hardly mild. I mean, they need a lot of support to adapt and meet the challenges of the world. Intellectual deficit classification has a checkered history at best, because all too often when someone got put into a classification, that meant what educational program they got put into. So if you had this IQ, then you went to this separate school, or you went to this life skills program, or you went to this and that. So it was often aligned with educational placement. It didn't really tell us too much what to teach and provide a lot of instructional value. So, but that's what we continue to do. All right. I'm going to shift gears a little bit. And now that we have made a distinction between naming, defining, and classifying, I'm going to talk about a medical model of understanding the disability versus a social ecological model. Prior to 1992, in all the leading organizations, the medical model ruled. The name was mental retardation. The focus was on identifying deficits, intellectual and performance through IQ and adaptive behavior. And the basic assumption was that intellectual disability was a defect within the person. Mental retardation was a trait, like having brown hair or blue eyes. And there are some people who still very much buy this, who I have a lot of respect for. But I was chatting with a person at last year's conference, and her and I had worked together. And I was sort of just saying that, this old way of understanding intellectual disability is a trait. Like, she goes, no, it is. It is like blonde hair and blue eyes. And so, according to a medical model, it is something inside the person. Okay, it's a trait. The focus of professional efforts were on fixing or caring for the person, and there were medical interventions, but also behavioral interventions. So it doesn't matter. The notion is this person has deficits, and let's try to fix them as much as possible. Okay. A socio-ecological model was in the shadows, though, and Jane Mercer in the 1970s, Sharon Landisman Dwyer's in the 1980s, people began to talk about how there are some real limitations of totally viewing intellectual disability as a deficit trait. And so, in 1992, this manual came out by the AAIDD, and it was revolutionary in the sense of the theme was to hold the medical view, the medical model of intellectual disability in question. Now, operationally, the focus today is still on identifying deficits for diagnosis. And there were some goofy things about this manual, in that they stuck with IQ, which wasn't goofy, but what was goofy was they identified adaptive behavior as consisting of these 10 different areas. And there was no research, no empirical evidence that you could split adaptive behavior into these 10 areas. I mean, we'll look at the areas later, but for example, there was a leisure area and a work area, and to say that someone needs a different set of adaptive skills to participate in leisure activities and work activities, those aren't independent areas. There's obviously some overlap there. The contribution was that they said conceptually intellectual disability should be thought of as a state of functioning, as the mismatch between personal competency and environmental demands that could be addressed through providing good supports. So there wasn't a denial that the person has some limitations. Okay? So that was consistent with the medical model in a sense. But what they said was a social ecological model says that the person should be understood by the gap between their competencies and the demands of the environment. And it's that gap, that mismatch, that is the essence of the disability as opposed to the limitations. The theme was to focus professional efforts on identifying and arranging individualized supports. And so this was controversial at the time because they had those 10 adaptive skill areas which no one liked. Well, I guess the people who wrote the book liked them, but those 10 areas to the side. And people said, well, what are you doing this? There's no scale out there, adaptive behavior scale, that's going to give you scores across those 10 areas. The IQ upper limit, what they were trying to do by saying it was 70 to 75 was they're trying to account for the standard error of measure in IQ test. But they should have said that. They should have said, okay, we're going to keep it at 70. But when you make a diagnosis, consider the standard error measure, because one guy, a person might score 71, the next day they may score 68. But by saying 70 or 75, people said, well, if that's the range for the upper limit, that means someone scores a 75 and then the IQ test has a standard error measure of 5, you could get a diagnosis based on an IQ score of 80. And, it gets back to this bell-shaped curve. If you go up to 80, theoretically, you've tripled the population, the potential population. So that was very controversial. They said, let's start classifying people by intensity of support needs, which is not a bad idea, to try to understand people by their intensity of support needs, but they didn't have a standardized measurement tool to measure people's intensity of support needs. There wasn't a uniform procedure, and they also said let's no longer classify by level of deficit, and so that left like a big void. And if you need to classify, how do you classify then? So there was a lot of controversy, but interestingly, there was really very limited questioning of this idea of let's move to a socio-ecological understanding. Right now our assessment procedures just focus on identifying deficits, and wouldn't it be better if our assessment procedures looked at the gap between the person and the demands of the environment, and let's start understanding the person that way. So the idea was pretty supported, the big idea, although parts of the manual were questioned. They did that classification by support needs in a strange way too. It was really done by a group process. So you talked about communication, talked about a support function, talked about activities, and then came up with a rating of intermittent supports, limited supports, extensive supports, or pervasive supports. The upshot was if I were to run this sort of focus group classification scheme in Illinois, and you were to do it in Indiana and someone were to do it in Iowa, we all might come up with completely different conclusions. And if you're going to classify and if you're going to measure, you can't have such inconsistency, between teams. So that was their first shot at it, though. And that system was thrown out when they came up with the 2002 manual. They dropped the 10 adaptive skill areas and replaced it with 3 dimensions of adaptive behavior, which do have some empirical support. So conceptual skills, practical skills, and social skills. They specified now a 2 standard deviation limit and said that psychologists should consider standard error measurement. And they allowed that, yes, there were multiple purposes for classification, and classification should be driven by what purpose you want to accomplish. And so, for example, if a researcher wanted to look at this intervention, it might be very helpful to classify by level of deficit, so you know what sort of group is getting this intervention. There's also some usefulness to classifying by etiology if you are, a medical person. They still thought that it would be a good idea to try to build towards classification by support needs. The real issue too, though, nobody was using the classification by support needs when the 2002 manual came out. The last manual, and then I'm going to stop talking and I'm going to share some materials with you, changed the name to intellectual disability. As I stated, they were very careful to say that just because the name of the disability has changed, that doesn't mean the population has changed. So the definition was exactly the same. But one real contribution of this manual was they made a distinction between an operational definition and a constituted definition. And an operational definition focuses on the operations by which the construct can be observed and measured. All right, so adaptive behavior scales and IQ tests have been around a long time. They have a history. They have psychometric support. And so they said to make a diagnosis, these operational tools can be helpful. And so the operational definition has stayed the same. 2 standard deviations below the mean, evidence of adaptive behavior deficits in practical, social, conceptual skills, and manifested before age 18. It's a disability development. But they said once a diagnosis is made, the person should be understood in a social ecological framework, and quite a bit of conceptual work went in to describing what factors one should look at in terms of the mismatch between the person and the expectations of the environment. So here's just a quote. The major difference is in regard to where the disability resides. The former construct, mental retardation, viewed the disability as a defect within the person, whereas current construct, intellectual disability, views the disability as a fit between the person's current capacities and the context in which the person is to function. And so here's a little picture for you. You have the demands of the environment. The old way, or the medical model, was we look at deficits in personal competence, and that's how we understand intellectual disability. The new way is we consider these limitations in relation to the demands of the environment, and if there's a significant gap that others in society and other children in the school do not experience due to deficits in personal competence, then you have a social ecological understanding. And this is seen as more functional, because if we do a good job of understanding the gap between personal competence and the demands of the environment, then we can provide individualized supports to address the gap.